I sent
Which
it to
journal?
supportive care in oncology.
Supportive
Supportive care in
cancer.
cancer. Yes.
Yeah, okay, because sometimes they send it to me from that
Yes.
journal, but sometimes I just, say I don't have time, don't have time. A lot
Yeah,
from
so
Frontiers.
yeah, so they asked
Frontiers.
for they asked for like 3 reviewers, and I needed to
Yeah,
send them in a matter of 48 hours, and I couldn't reach out to you.
No,
So I
that's
just
okay.
sent it. I just sent it.
Well, that's good that you told me, because if they come from this, I'm going to open the email
Yes.
and yes.
Yes,
Say
please.
that. Yes, of course. It's a nice journal.
Yes. So I think, hi, ma'am.
Hi, Radha.
Good evening. How are you? Hi, Esther.
Hello.
How are you, Vanessa?
Good, and you?
Oh, yeah. Waiting
In
to
warm
listen to you.
India, huh?
Good evening, Kiran.
Good evening, Dr. Radha. Just trying to get VP in. She's having some problem with her net. So just try to get her in and connect. One moment.
So what's the time there for you, Vanessa?
It's 8 o'clock in the morning.
Oh, good.
Quite late for me, because I usually take the Zooms at 6, but this time I said, okay, I won't go to the hospital. And Dr. Singer, he came to Mexico to give some LLS, so he WhatsApped me if I could go pick him up and take him somewhere. So I'm going to do that today. So today is like a free,
So after this, you're free.
relatively free day. After that, I'm going to go to the hospital, check on my patients, one of the private ones, and then take my son to the stock market, because he's taking a course about finances and so forth. So I'm dropping him there.
So your hands
and
are
then go
full.
to pick up Singer.
Okay.
So today is weird. So I'm starting late. But
Yeah.
happy.
Yeah.
Dipti, she's here.
Yeah.
Hi, everybody.
Hi.
Hello.
Hi.
Hi,
How is
Dipti.
everybody doing? Hi.
So everything is set, Kiran.
Yeah, everything set. Deepthi, you got the host controls by now?
I think I did.
Yeah.
I think they're still
We
giving.
have about 360 registrations. We'll take 100 on the Zoom. The rest will be on YouTube.
Awesome. That's great number.
Yeah, that's wonderful. Okay. So let me just check.
So
Vishnu,
it still says there are people on waiting room.
yeah,
Yeah,
we
yeah,
just
you have
wanted
to.
all of us to check out. If everything
Yeah,
is okay, then we hand it over to you, and then they will
you
be
need
ready.
to make everyone enter the room.
Yeah, that's
Oh,
right.
me? Okay. I get the
Yeah,
privilege to do that.
you are the
Yeah.
only host, Dipti. If something goes wrong, then
No. Nothing will go wrong. Everything will be perfect. No
Okay.
going wrong.
All
Yeah.
set. I'll just ask him to get you on.
So Kiran, is he going to?
Yeah, he's going to let people admit once I give him the update. Are we all set? Can we?
Yeah. Yeah.
Yeah, perfect. Okay.
It's so good to see everybody.
Deepthi, you can take over.
All right. Thank you, Kiran. Hello, everybody. I still see there are more people joining in. So maybe we'll give a minute exactly, and then we'll get started. This is super exciting to see so many people being interested in our initiative and want to learn more about it. This is wonderful. I can already see that this going to places and a lot of people, interested to use the tool. It's wonderful. Okay, I think we can go ahead and get started. If that's okay with everybody. I'm sorry. Yes, Vanessa, did you say something?
No.
It wasn't you. Okay. All right. Welcome everybody to this webinar hosted by NutriHealth Foundation. Thank you so much for joining this. We have a very good line of speakers today. Our webinar today is going to be about advancing cancer care through nutrition. And we'll be talking about a very innovative global collaborative research initiative. We already see there is a huge response that we received for this webinar. We are super excited, and it's our honor at NutriHealth Foundation to host this webinar and have all these experts join us today. Thank you so much. So I'll quickly go ahead and start introducing our speakers for today, and then we can take off. First of all, I would like to introduce our speaker, Dr. Vanessa. Hello, Dr. Vanessa. Thank you so much for being with us here. Dr. Vanessa is head and founder of Clinical Nutrition Department in Hospital General de Mexico in Mexico City. Thank you so much, Vanessa, for being part of our global initiative. Vanessa has about 20 plus years of experience in clinical nutrition research and academic teaching. She leads a lot of global collaborations in cancer and critical care nutrition. She is an internationally recognized speaker in nutrition science. We are very delighted to have you today, Vanessa. Vanessa also has a MD. She's a doctor by herself, and she also has a PhD in clinical nutrition. And not just that, she's a registered dietitian as well. So that's amazing. And to see a doctor have a registered dietitian license is always a dream come true. So you know what the perspective of dietitians is. So that's wonderful. Not just that, she also has advanced training in clinical and policy-based nutrition. Coming to her research and publications, Vanessa is a contributor to multi-center studies in oncology and chronic disease nutrition. She published in top journals on medical nutrition therapy and malnutrition. And not just that, she's also a co-author of clinical guidelines and book chapters in many books. Her research focuses mainly on nutrition equity and culinary tailored care. That's amazing. Welcome, Vanessa. Thank you so much for being with us today, and we are looking forward to get your thoughts on our topic today. Moving on, we have our very own Dr. Radha Reddy Chara. Welcome, Dr. Radha. We are very delighted to have you here on this webinar today. Dr. Radha has a PhD. She is also a registered dietitian, and she is a lead consultant clinical dietitian and head of the department at AIG hospitals in Hyderabad. She has more than 25 years of experience in nutrition research, teaching, and clinical dietetics, and she leads the clinical dietetics department at AIG hospitals in Hyderabad. So if you happen to be in AIG hospital, go say hello to her. She's very warm, she's very welcoming, and she's a very, very good teacher. So make sure you go and say hello to her. She's also a founder of Southern Chapter of SRNM and executive member of IDA Telangana. She is president-elect of ISPEN. Thank you so much for being with us, Dr. Radha. And not just that, Dr. Radha has a PhD in clinical nutrition and dietetics. Like I said, she's also a registered dietitian. It's amazing to see everybody being registered dietitian on panel today. And she completed an advanced certificate course in renal nutrition. Dr. Radha Reddy has published in Aspen, ISPEN, and many other peer-reviewed journals. Her recent topics include ICU nutrition and COVID-19 nutrition strategies. She presented papers at many international conferences, including ISPEN, PENSA, and AICNU. Thank you so much for giving us your time, Dr. Radha. We welcome you on board to today's webinar. And now we have Dr. Esther Satyaraj. I have been seeing and working with Esther for more than 20 years. And it's always so good to see you, Esther. And it's very the enthusiasm that you bring to board is really amazing. Today, I would like to introduce you as a speaker in our webinar. She is the head of clinical nutrition department at HCG Hospital in Bangalore. Dr. Esther also is a registered dietitian, and she has over 20 years of experience in clinical nutrition, especially in oncology, gastroenterology, and critical care. She's currently leading the entire clinical nutrition department in HCG Hospital, Bangalore, and she leads a team of dietitians and oversees nutrition care protocols for cancer patients at HCG. She actively conducts many workshops, webinars, awareness programs on oncology nutrition, and she's an expert in the field. She is an executive member of SPEN. And not just that, Dr. Esther also has a PhD in clinical nutrition. She's the program director for the fellowship in oncology nutrition at HCG and a registered dietitian herself with Indian Dietetic Association. Coming to Dr. Esther's research and publications, she has been published in many peer-reviewed journals, and she presented many papers on cancer nutrition and enteral and parenteral strategies. Her research on chemotherapy-related fatigue and high-protein diets in breast cancer has been really pioneering, and she presented research at many national and international nutrition conferences. Thank you so much for being with us here, Dr. Esther. Dr. Esther has been one of my mentors as well. Not that I want to make you look older, but I just wanted to share that you have been amazing impact in my career as well. Esther, thank you so much for being with us here. Without much delay, I would like to continue into the next part of today's webinar. Okay. So next, we are going to have a presentation by Dr. Vanessa. Vanessa is going to give us an overview of global collaborative research on cancer nutrition. After that, we are going to have a panel discussion that has been moderated by Dr. Esther. And all three of our speakers are going to be in there as well. Once we are done with that, we will have a Q&A session where the panelists are going to interact with the audience and answer some of your questions. And then we are going to close today's webinar. So in the meantime, if you guys have any questions, please make sure you're putting it in the chat box so we can look at it and ask the speakers as we go. And one last housekeeping thing that I would like to announce is for all the participants, if you would like to get your participation certificate for today's webinar, please make sure that you're filling out the form that we have posted in the chat and send it back to us so we have your information and we can send you your participation certificate. All right, over to you, Dr. Vanessa.
Okay, I will share my screen. Well, I want to introduce you to this global collaborative research in cancer nutrition. That is an initiative that started when one of the times that I was in India with my Indian friends and colleagues who are really interested in having some information of what we do. The first idea started by India and Mexico or Latin America, but then it grew to everywhere because there were many people interested in collaborating with the idea. So why do we want to do that? Because there is a lot of information and guidelines to nutrition approach in oncology patients, but there is no detailed information of how the nutrition care process would develop in different countries, especially in cancer patients. So that initiative arises or why it arises of how, who, or where they screen, they assess, they implement the nutrition techniques or the nutrition in general. For example, what diet is used. We know that, for example, in the Indian population, many people are vegetarian, and we wanted to know if that makes the patient have the same outcome or not, or if a vegetarian diet influences in the amount of protein that they're allowed to or they can achieve. So that was the idea first of why do we want to do that. What are the benefits? Well, obtain the information that will serve us to compare nutritional care of oncology patients in different hospitals around the world, and thus to generate eventually a consensus or another type of guideline, but based on evidence and data that will allow us to standardize this process and plan precise actions to improve nutritional approach and prevent or treat malnutrition in cancer, that we know that it's very frequent. It's more than 50% according to the papers that we have in literature. So the objective was to explore the management of nutrition care process and outcomes of oncology patients in different centers around the world, because everyone in the world is included, that decide to participate in this data collection to obtain information on the practices of nutrition care process in oncology. What do we want? Well, first, we want to collect at least 50 patients per hospital, which obviously we know that in these cancer centers and big hospitals such as where I work, it's not very difficult to find 50 patients that we can follow for at least a couple of days and then write down when do they are released from the hospital so we can have the outcomes. So that is the goal, to collect at least 50 patients of each center. The inclusion criteria would be hospitalized or even outpatient patients treated in different centers who agree to participate in the study and sign the informed consent form, which it's very, very important for approval of the ethical and scientific committee, which we have done with our hospital. And of course, we do have a number of registration already. So the informed consent is part of the consultation visit. In fact, in this project, we developed 2 informed consents. One is for the patient to use the data, their data anonymously. And the second one is for the center that accepts to participate. No? So it's worth mentioning that this data that we're collecting is routine data, is not specific data for the study. We want to know if you do, for example, bioimpedance, or if you do strength registration with certain type of instruments that you may have or you may not have. So everything that you put there counts. But usually what we want you to register is the usual data that you register for your practice. It's nothing more than that. So, well, this is really the identification of areas of opportunity and establish more precise recommendation for nutritional management in oncology patients that can be used by any professional in the global community. And we hope that with this, we can optimize the quality of life and clinical outcomes of the patients and try to promote nutritional care in the areas that nutritional care is not like part of the normal or usual care for oncology patients. So what do you have to do? First, we have NutriHealth Foundation that made us a very nice way of registering all this data that would be easier for us to analyze at the end, because it has a very nice display and very easy to use. You can, you can fulfill it with a computer, but with an tablet, or also with a cell phone. And you have to first register, which is to collect the information with your QR code that appears here, for example. And you have to register the center. And then the team will send you a specific number for your center. So whenever we analyze the data, we can analyze the data by center or by country or by region. Well, we can do whatever it's necessary. So you will receive an email confirming the successful registration of your data with your special number or code that is unique for your center, and then a link that leads you to the database. What is the database? Well, the database consists in a registration of the patient's name, the hospital name, and your code. Once you have it, then you register the data, but not, I mean, you don't have to register, obviously, the name of the patient because that's anonymous, but the ID, the patient identifier, if you want to, that is not like mandatory. You can only put the letters of their name or whatever. Patient's age, gender, occupation, country. Some are mandatory, some are not. And the type of treatment, if it's inpatient or outpatient, condition specific type of, and everyone it displays, and you can choose one of the choices. You can add the performance scale, the Karonovsky or ECOG, or both. What else? Another one is which nutritional risk screening tool you use. If you use GLIM, MOST, well, so we can identify that this type of data, height, weight, calf circumference, BMI, whatever you use, you can register. Some of the laboratory works, for example, in our hospital, we don't use prealbumin because we don't have the, the money to get prealbumin for all the patients we want, so we leave it in blank. Same as, for example, vitamin D levels, and in case you have them, that's wonderful because we can get even more information with that. Type of diet, for example, vegetarian, non-vegetarian, vegan, and all that, which is very important for us. And you have to calculate the amount of kilocalories, protein, and carbohydrates. If any dietitian that is participating, they can get all this information as well. And then the nutrition intervention plan. And if you fulfilled or didn't fulfill the nutrition goals that you have for each patient. So that is another thing that we're registering. And if you are having a patient with parenteral nutrition, central or peripheral, if you have oral supplements and you want to add the name of the oral supplements that you're using, what type of nutrition, for example, it's like anything that you would anyway register for your practice. Is not more than that. And that is the idea. And we are inviting you to join this initiative. And of course, I'll leave you with the other two speakers that we have, and Deepti take over the coordination of the symposium. Thank you.
Thank you so much, Dr. Vanessa. That was a very wonderful overview of the tool. Like I said, if anyone has any questions, please put it in the chat and we will go over it at the end of the session. And again, there is a form that you need to fill out if you want to get certification. Please look at the chat and you can do that. Now we are going to have our panel discussion moderated by Dr. Esther. Esther, please take over.
Yes. Thank you. Thank you, Deepti. Thank you, Dr. Vanessa and Dr. Radha. Thank you for joining us today. So I don't have any slides. I'm just going to have it like a discussion where we are trying to understand why is it important for us to collaborate in a research like this. From an Indian setting, all of us want to be involved in some form of a research, but we really haven't gone beyond our hospitals and gone beyond our departments, collaborated in a multicultural, multi-country level. So just need inputs from both of you on why is it important, number one, and what are we going to learn in the whole prospect. So I'll start off with Dr. Vanessa. So from your vantage point, because you have done, you have led a lot of cross-country research initiatives. What is a pressing need that you see in oncology research or oncology nutrition research?
Well, first of all, it's a new area. I mean, we don't have so many long-lasting publications about nutrition in oncology because it's a new area that we need to really end up understanding what is the relationship between nutrition, that we know that it's very important, and the outcomes of the patient. And many people, as you said, Dr. Esther, are willing to know how research is done. And I mean, taking these research courses may be really boring and they'll show you, research methodology and all that. But I mean, we know that we really learn how to do research by doing it. So this is like an opportunity for you to get involved in how you do research, how you do a database. And of course, you have to have that approved by ethical and biosecurity committees and all that. That has been done in this project. We do have an approval. It took me like 6 months to have it approved because this is a long and bureaucratic process, but we do. I had a lot of questions from Latin America because, this bureaucratic is all over the place. So many of them want or must put their own committees. Also, Australia asked me to give them the letters that I have and the approval and so forth, because it's easier for their own committees to have it approved in their own centers. But this has been done. We have a long way already to show you and get you the database, and because we have all the approvals already and all that, but you can use all this information in your centers. Some of this information is in Spanish. I will translate it to English, no problem with that, and send you all this. The protocol is in English, the informed consents are in English, but still the approval letters are not in English, but I can, do something so you can have it with the seal and you can have the original. Yes. So this has been, done. So I think that, for you, it would be easier to just register your center, and you register that in your hospital, and maybe that will be the first step for each one of you to start research in your hospital, seeing that it's not such a difficult thing to do.
Right. Okay, so coming to Dr. Radha, because you have already been part of multi-country research, number one, and also multi-centric research. So there are multiple hospitals which have joined hands with you and have collected data. How do you think, from an Indian perspective, we can contribute to a global data collection?
Yeah, thank you so much. Actually, these are kind of coming in now, although we are there. When Deepti was actually introducing me, she said Radha has 25 years of experience, but then these invitations or this kind of work where we can have multi-centric trials or multi-country trials or things like that is coming up now. And it's a great learning for us to know what they are. Although there are certain individual research outcomes which we keep reading, but then it's also to showcase who we are. Right. So that's an important thing. And then you have a comparative to know where can we go forward if we are looking at countries who are progressive, or where is it that we need improvement, or where is it that, how is it that our decisions are different in terms of treating a patient or looking at patients, depending probably our income status or the facilities or the logistics that we have. So how different are we? Even if, like Vanessa, when she was presenting, she did talk about GLIM. How different are we from body composition? And does that have an impact?
Right.
That's something that probably such studies where we compare, we get to know each other.
So just to add on, so in India, one of the challenges that we face, Dr. Vanessa, and what Dr. Radha would see daily in her practice is, one is late stage of presentation in oncology. And a lot of sectors in India can see patients who are already severely malnourished. Now, would that impact your data collection in any manner? Because early detection is still not very upfront in India for cancer. So by the time we meet them, the patient could be in advanced case of cancer, and multimodal, lot of therapies, immunotherapy, radiation, combination of different therapies, and would also be presented malnourished. Would that impact data collection in any manner from both of you?
On the contrary, dear Esther, it would make a point there. It would make a point, because if we can demonstrate that this influence, then with this information, you can impact the oncologist in your hospital to prevent that to happen. to send you the patient on time. So I think this information would be really, really interesting for them as well. I think so.
Yeah.
So
Dr.
for
Radha,
us,
would you want to
yeah,
add on?
for us, Vanessa, what happens is the screening itself is delayed.
Yes.
That's the problem. It's not that the oncologist is at fault in sending us the consults to the nutrition department, but they presenting to the hospital itself is delayed.
I know that
Yeah.
happens also in certain regions of
Yeah.
Mexico.
So they do not come in stage 1 and stage 2, probably stage
Stage
3, when
4
they know
stage,
that
yeah.
when they know that it's really impacting their day-to-day activities, or whatever, be it eating, be it performing, be it whatever movement, then they get a doubt, and then there is some nice doctor tells that there is a larger issue in you, so you go to a bigger center. So this is what happens. Probably the populations are not so well educated or health educated. Let me put it that way. They are educated per se, probably up to 10th class or maybe even little more than that. But then health education is very, very poor here in India.
Would that impact data collection in any manner?
Yeah, so that's
Or
something.
would
it will
It
impact.
won't.
I think on the contrary, it will give us way more information, Esther, because that's important. The point would be then that we should see the patient before. You should screen the patient before, and maybe because they're collecting the data, they will pay more attention and screen them before.
Yeah. Also, I think it's also not with a curative intent. I think you had one paper, Dr. Vanessa, you can highlight that, where you knew that nutrition intervention, or rather you found in your research that nutrition intervention is not just curative, but actually it helps in improving the quality of life.
Yes.
So if you would like to add on to that, either Dr. Radha or because I think both of you have done work where you didn't look at the outcome as curative intent of cancer, but you looked at frailty, you looked at fatigue, you looked at other quality of improvement parameters. And if you could briefly discuss that, it would kind of help the nutritionists who are part of this program to understand that our interventions need not always be curative intent, especially if you see patients who are in stage 3 and stage 4. And we should understand that we don't starve them because they are in advanced cancer stage.
Yeah.
So could you just elaborate, both of you, please?
You want to, Vanessa, first?
Go.
Oh, okay. So what we have to remember, yes, as you said, it's not just for cure. It's not just about correcting the disease. It's also that probably helping to correct the impact of the medication that is given to them. Nutrition does help to cope up with the medical treatment that is given to them, or probably to cope up with their day-to-day activities, to put it as simple as that, because we really don't know how well social help they would have to cope up at home. So improving their nutritional status or their nutritional intake would help them to be more independent than be dependent. So these are things that you have to look at a larger perspective than just looking at giving it a cure to the disease itself.
Can you speak about the PENSA paper?
Yeah,
briefly, just for people to understand.
Yeah, so what we did, we took patients who were with pancreatiodectomies and did their body composition. So all their body composition was where they said they are sarcopenic, and then we had a good percentage of them with frailty and sarcopenia. But we continued to give nutrition. We counseled them well. They got discharged. We followed them for 1 year after pancreatiodectomies, that is after Whipple's procedure. And so the treatment was only that they had the procedure, or they had the surgery, or the Whipple's procedure, but the nutrition was, kind of managed. And at 1 year, we had 60% of them where they were independent of their work, although they were sarcopenic. So that's what nutrition can actually work. It's not just correction of the disease, it is correction of the disease and nutrition. And
Right.
probably we trained them in physical training also, how we told them what is the importance of doing their day-to-day physical activities, daily activities, with some interventions to improve their outcome. So this is what, so 60% of them, although being sarcopenic, are doing well. And the SARC-F score came normal at 1 year. That's something that, and their grip strength improved at 1 year. So these
Right.
are things we can say that it's, and probably the sarcopenia effect or the malnutrition was because of the disease. Their nutritional status improved because you were providing nutrition after the correction factor. We could
Right.
always come to conclusions that way.
Dr. Vanessa, would you like to talk about it? Because
Yeah,
I remember,
think-
yeah.
No, go
Uh,
ahead, Esther.
I remember when you came down to India and you had the session with us, you presented a paper where you had advanced cancer patients who could barely walk or who had very high fatigue scores, and you gave them good nutrition interventions, and then you followed them up while they were in the hospital. And I don't know, I mean, visually, I remember you saying something like she could walk. I mean, one particular patient, she could walk in the hospital fully after she received intervention. So could you just highlight that?
Yeah, I mean, it's not the same to read like papers that says you should give them nutrition, blah, 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 that to see the data in
Right.
your own hospital and to see the impact that your interventions have on patients. So in my case, I do clinical practice as well. So I am a witness of how
Right.
it really helped, because when they
Right.
don't do nutrition, they come really very weak, in very, very bad conditions. And then you give them nutrition and they improve, and you can
Right.
see the improvement. But it's not the same to see it in several patients, because the
Right.
more I treat, and more, probably 100 patients or
Yeah.
whatever. But it's not the same to have all these data from
Right.
everywhere and see the impact of what they do and the outcomes. And we
Right.
can compare who does this thing and the outcomes were better, and
Right.
to analyze why they were better. So that is the idea of doing this humongous collaborative research,
Yes.
because we can explore exactly what are the reasons and what are the best nutrition interventions that may improve the outcomes. That's why one of the main important points that we must have in this registration is the outcomes of the patients.
Yes, yes.
And how many days you couldn't fulfill their requirements, and how much that impacts the outcomes. You know what I mean?
Exactly.
Yes.
Which is what we want. We want to improve outcomes.
Right.
Yeah.
Okay. Okay. So just to summarize this section where the two of you contributed, for the audience sake, two things. One is, even if we see advanced patients and even if they are malnourished at the time of presentation, nutrition intervention still makes a difference. And you don't have to be hesitant to be a part of this collaborative research just because you are seeing advanced cancer patients or seeing patients who are really malnourished. The second very important point that both of them brought out at this time is nutrition interventions. We have to look at our outcomes, and outcomes need not be all the time with curative intent. But as nutritionists, when we do an intervention, and I think that's very important for us as nutritionists, because we are very good in planning diets and implementing the diets, but we never really look at outcome measures. We don't see frailty, we don't see this hand grip strength that Dr. Radha was speaking about, or we don't see whether the patients are improving on our nutrition intervention. So just to summarize 2 points, being part of the research doesn't need us to see patients who are at early stage. We can see whomever we are seeing. The second thing is, for our own learning, it can be a very insightful research that we are doing to understand whether the patients are actually improving in the interventions that we are giving. So moving on, we have, let me just ask a couple of more questions before we wrap up for this. How do you think collaboration works? I mean, suppose you have got a lot of data from one country and not so much data from another country. How would you still, manage working on the data and extrapolating the results. And also, Dr. Vanessa and Dr. Radha, how many other forums have joined hands with us for this collaborative research?
Well, as I told you when I gave the short presentation, we can analyze per country, and we can get information of the country that we have the most interventions, but we can also analyze per region. And also we can analyze, for example, limited resources country as opposed to non-limited resources country, and see if that influence or not. I mean, we can do so many things. So it doesn't matter if one country has more and more, or one city. For example, what if Hyderabad has 20 centers and Chennai has only 2? You know, it doesn't matter. I mean, it doesn't matter. We can also analyze per city, or we can do many
Right.
things if you're interested in.
Yeah,
Right.
very true, Vanessa. It's like the Nutrition Day analysis.
Yes.
The Nutrition Day analysis gives you a comparative of where your center is as compared to the other centers in the same area, where your center is compared to Asia or your own continent, where your center is compared to globally. So probably that gives us insights of our own country and then compared to a similar level country also. So that's I think it's possible.
Yeah.
But
Okay, from
data,
yes,
so
please add on.
data is going to be important for her, you know, for analysis. The more the merrier, yes, but then I think it doesn't stop her from analyzing.
Yeah. Okay, so apart from having a research contribution for individual dietitians, now this from I saw the form. I have worked on the form as well, so I know that the form has to be filled by the clinical nutritionist. So this is an exclusive dietitian driven research clinical trial. So apart from the dietitians contributing to clinical research, from an individual perspective or from a practice perspective, how do you think it can help her to develop further from where she's working? Could you elaborate on that? I will add on.
Well,
Like for example, what you had said. Yeah, go on, Dr. Vanessa.
I think that it can help a lot to see what are we doing around the world. For example, regarding the I don't know, the nutrition assessment, for example. If we do only with bioimpedance, or if we still do measurements with tape, and which is the measurement most used and why, you know what I mean? Because now they're using a lot the calf circumference. I don't know if everyone is using it, or it's aware that you can use calf circumference as one of the outcomes, but it's very, or one of the parameters that it's very easy to do, you know?
Right.
So we can get information also, and people can learn also, because probably they never imagined that they could use calf circumference, and they say, oh, that's interesting, and they look for the paper, they read the paper, and they read it. So that can be very interesting for people who are not really into that all day long, you know?
Yes. Dr. Radha, would you want to add on to what she said? Like, how would collaborative research or just participating in research not help an individual, I mean, help a nutritionist working in a hospital setting develop herself further?
Yeah, so that's a individually driven motivation that we all have to work on. That's point one. Point two is probably looking at all the questions the dietitian can actually learn. It's a learning process where we get to learn that all these parameters are of importance, and that's why we are doing research on.
Right.
Or probably they have never done a certain concept or a question which has been there about certain concepts of nutrition intervention or nutrition assessment. Probably that's one way to say, okay, let's try doing it and then see what's the outcome. So it's like giving a lead too for a patient who's not aware that this can be done.
Right. Okay. So just to summarize this little part for all the participants, being part of the research not just helps us to be part of a global collaborative research, but also can help us in changing our practice and the way we are doing the interventions for the patients. And it can be, the whole thing can be an extreme learning experience. And we will be able to learn from the best practices, not just from the city, but across the globe. So, at this stage, what I'm going to do, so I'm done with asking questions for the two of you. So at this stage, I'm just going to leave it open because we have another 10 minutes before we wrap up. We have, the forum is open, I think, Dipti, isn't it? For people to
Yes.
ask questions, and three of us are available to answer to whatever best capacity we can.
Okay. Thank you so much, Dr. Esther and Dr. Vanessa and Dr. Radha. That was very, very wonderful session, panel discussion by you all. And I agree with you, Dr. Esther, that this tool is not just, about collecting the data or being part of a research program. It goes beyond that. It goes beyond the boundaries of just practicing in your own hospital or in your own city. It's being part of this global initiative where we can be setting all these guidelines for many more years to come and many more generations of dietitians to practice in their field. Thank you again. And I do see questions popping up in the chat window. So I'm going to go ahead and start reading the questions so any of you can start answering. The first question that we have here is, since I am located in Bangalore, will I need to take permission for hospital to collect data? Will a consent or MOM be provided to us? Dr.
Yeah, I
Esther, would
do
you
have
like to answer
the
that?
informed consent form. I just have to, send them for you to distribute, and I'll send them to you in English. And if you have the authorized one with the seal and everything, it's in Spanish, but I can send that to you as well. Mhm.
Okay. All right. Thank you, Dr. Vanessa. And the next one that we have here is just, I think they shared their thoughts. It says prevalence being very high, extensive research is really crucial for preventing and managing. I agree, Shweta. That is right. That is a whole point of this whole initiative and why we are doing it, because the prevalence of cancer is so high, and it's very important for us to have tools like this. Thanks for sharing your thoughts. And another comment says that thank you for coming up with the initiative. Great effort.
Okay,
So
so
we are
while the people add on questions, let me just talk about the form. Dr. Vanessa
Yeah.
can add on. So the form is not very elaborate. It is more of drop down stuff where you can just tick rather than having to type. As Dr. Vanessa said, the team of NutriHealth Foundation really supported us in making the form. It has the components of screening, assessment, intervention, monitoring, and outcomes. It's a form that is easy. So once you register, you can see how you can try it out and see what are the challenges that you face. But it's not we have tried making it very user friendly and not something where you have to type in a lot of information. And except for where you have done the calculations of calories and proteins and what is the deliverables, that's at one place maybe you will have to type, but otherwise most of it is drop down things. Dr. Vanessa, I think they've started using the form, so she can add on if
Yeah, it's very
that'll
easy.
be great if you can
The
add.
only thing that we have noticed is that we have to wait until the patient is released to be able to put the last part, the outcome and the number of days in hospital, for example. That is why we haven't, we have one patient and we want to turn in the information, but we wait until the end and then we collect everything and we put the patient on. So that's the only thing that we have to wait until he's released so we can have all the information and then add the patient. But you can access anytime you want the database, so it's easier.
I'm going to go ahead and ask a question, if that's okay, Dr. Vanessa. What has been your feedback from the people who have already started using the form?
Well, for example, one time, because before we couldn't add at the same time ECOG and Karnofsky. It only allows us or ECOG or
Yes.
Karnofsky. So I had to change that because we usually have both and both are important. So we
Yeah.
put both. So we have been changing details while adding information. So I think the form as you can find it now, it's better because you can have all these choices. The same as if you use Gleam or if you use another one in a hospital, we use Gleam and we use NRS 2002. So we can put both, for example. So those things have been fixed and I think it's very easy to use. It's not very difficult. Of course, we can add more information, but that would make us very, tiring to fill out more information in the database.
Yeah,
Yeah,
we can have
it's
it like a tier 2 project on this.
Yes, we should. It's wonderful that it's so user-friendly and easy to use because I think that's a key because as such dietitians are swamped with so many things in the hospitals and in their practices. So to keep it bare minimum and make sure that they can do it, as easily as possible is a key. And I think this tool nails it. So that's wonderful. Let's see. I think we have a couple questions here. So can this research be a mix of individuals who are on cancer treatment? They can be dear ones too. So let's suppose we take few from hospitals, clinics, few from dear ones. I guess what they are trying to ask is like, can we also collect this information, not just in hospitals, but anybody that they know who has cancer is what I'm thinking.
Yeah, but it says a number of hospital days. So the best thing to do is to get the patient in hospitals. You can also do it in outpatients, but you have to write down the outcome.
Yeah, if they can have that data of how many number of days they have been in the hospital, if they can fill up all the
Or some outcome like either the body composition or the calf circumference. Some outcome measure should be managed in an outpatient clinic.
Okay. So
So
the
dear
next-
ones, dear ones, as long as unless you as a nutritionist are monitoring them closely, it is difficult for you to include your dear ones unless you have access to all their medical records and they are taking treatment and you're able to monitor what you have provided, what are the gaps in your provision, and how does it impact the outcomes.
Yeah, I know it's tricky to have all
Yeah.
of the information. You're right. If they are following them in their care and they have all the details that are needed, I think it makes sense. But otherwise, yeah. Or maybe if you know somebody who's dear one and you think that that's going to be a good data point, maybe you can start following them moving forward and see how that goes, and then maybe have that as an option. That's a interesting question. The next question we have here is in end-of-life cancer palliative care, what aspects to look in while planning nutrition intervention?
Dr. Radha can answer that. This is more of more of practice related question than the research related question. But yeah, Dr. Radha, you can add on. You can.
So end of life, you're already saying it's end of life, but what happens in practices or in the hospitals is they say it is end of life and everything is stopped. Okay, so nutrition is their right and they get it till the end. So you have to focus on trying to provide nutrition because that is never stopped. Let it be end of life. In palliative care, again, so to what extent do you really so palliative care mostly means that you're giving relief to the symptoms that the patient is facing, but it's not saying that you have to change your nutrition. So the nutrition continues, whereas it's the symptom management or trying to relieve the pain, relieve the troubling factor in palliative care is what is more important but nutrition does not change. Am I right, Vanessa?
Exactly. No, I mean, it depends on the type of patient that you are dealing with, and also, unfortunately, also with the resources that you have, because Mexico is
Yeah.
like, yeah, in many ways, that you have the private hospitals where you can get all this new age chemotherapies and all that, and you can get all you want, but then you have the public hospital that you don't get this. So it also depends on the resources and who is treating you as well. So
Yeah.
it depends on many things. Unfortunately, if you get this diseases already advanced, it's very difficult to control,
Yeah.
So that is what we're heading. But still, it doesn't mean that you don't do anything nutrition-wise to improve quality of life, which is what we
Right.
also want, even in diseases that you cannot cure, those are the palliative care. But I've had palliative care patients for a year, with good quality of life, but they're palliative because they're not receiving any more, cancer treatment, but still they're there and you have to help them.
Yeah.
Right.
Yeah, that's so true. I just wanted to share one of the experience that I had when I was working in a long-term care facility many years back, and we used to have a section of, end of life patients. And what I noticed there is, even though all the other care stops, the nutrition, like you both said, still goes on. But the interesting thing was they used to have special requests. The care used to stop, but then they would ask for, can we have ice cream today? Or can we have, I feel like I want to eat, X, Y, and Z. I'm talking about, people who are conscious, of course, obviously not the ones who are like bedridden and can't eat and are on enteral feeds or parenteral, but there used to be people who used to ask, who on paper were on hospice, and they were like, not getting any other treatment. But so for me, it was like, I would go there, talk to them, and then just ask them, is there anything that we can provide at that stage? So it's crucial at that stage as well. And it's not like, okay, all the other care is stopped and nutrition can be stopped as well. No, it doesn't work like that. So I agree with you both. Just wanted to add that on.
Right to food is a fundamental right.
That's right.
In fact, right to nutritional care is also a part of right to food, which is a fundamental right, a
Mhm.
part of the human rights requirements.
So true. So
Yeah.
true. And that shows that we are in such a crucial position as dietitians. It's not like, okay, we are done with the medication and so it shows how crucial as a dietitian our role is in taking care of these patients.
Yeah.
Thank you so much, Dr. Radha, for that. I believe there is another question. I am a research scholar working on cancer-associated malnutrition and its dietary intervention. Will I be able to utilize this tool in the hospital where I do data collection? And is there any specific type of cancer that the global collaborative research is looking for?
Yeah, you
Dr.
can use the tool, and there
Okay.
is no specific type of cancer that we are looking at. That's what we discussed. The cancer can be early, late, can be any site, any tumor, staging. We are just trying to understand how is nutrition practices across the globe, and what is it that we can learn from our practice. So if you are a research scholar and you have access to cancer patients and you're keen to collect this data, we would encourage you to do it.
Yeah,
We
that's
would
good.
also encourage you to add to this poll. Probably you're going to collect data separately for yourself, but then remember that you can add on to this poll, because our outcomes or our analysis of the whole thing would give it a different perspective if more number comes.
Correct. Okay.
I think
we
a lot
have-
of hindrances that people can have is, you could be working in a multi-speciality and you might not see a huge number of cancer patients. But as such, we are just looking at, when Dr. Vanessa presented the slides, we are looking at maybe 50 patient data from each hospital, and that is enough for us to, start with that. So you probably might see just 10 patients in the whole month, and we still invite you to participate.
Yeah.
I just wanted to add one last question. What are the challenges that you anticipate that these dietitians might have? And
I
then we
think in
can wrap
India, the practice is very diversified.
up.
It's
That's okay.
extremely
Don't
diversified.
judge. Don't judge.
Yes. No, I'm
You
not judging,
have
but
to
you
let
know,
them
yeah. I mean,
answer.
like if I compare the practice that I have and with what Dr. Radha will have, we might be using different tools, like NRS at one place, SGA at one place. Many hospitals in India can have institutional screening tools as well. So our practice can be very diversified, but at the same time, it can be very interesting to see the data. And that is the reason when we were making the form, we gave a lot of options. There are a lot of options. Maybe a European country might not have as many options as we have over here, but there are a lot of options. In screening tool itself, I think some 10 options are there for people to just take whichever is applicable.
Correct.
Yeah, so I think that is one, but then that shouldn't stop us from collecting the data. That shouldn't
Right.
hinder us from collecting the data. I think irrespective of how our practice is, we should still collect the data to understand where and what is happening with our patients and what we can learn out of it.
That's wonderful. Thank you, Dr. S. Dr. Radha, would you like to add anything?
That's it. See, the thing is, even if it is very diverse, what's important is, even if you've given so many choices, what is important is for our own self, are we actually able to identify the patient who is malnourished? That should be our goal. Are we able to give the right kind of intervention for the right kind of patients? So that's the whole aim of trying to collect the data, trying to identify, and then see where are the difficulties, and so what is the way forward. Right, Vanessa? Is it like that? Yeah, that
I think
always are
that
looking at.
yeah, but I think that one of the main challenges that people would have with this is that they have a lot of work. So everybody is really busy, and they say, "Oh, I don't have time to register the data." But this is so easy that you
Right.
can even register the data and have that as an extra in your practice, and then we can have this analyze your own data, which is important, and that is one step forward to start doing research and registering your own practice. And they say, I think that is a way of demonstrating that it's not so difficult. It's like a little extra time that will
Right.
give you a lot back, you know?
Correct. Yeah.
Having order in how you register the data, because sometimes you go and you add, write down on these papers and papers everywhere. And I think that if we understand how to do it now in a very ordered way,
Organized way.
that's
Yeah.
a super plus for everyone, in
Right.
spite of the challenge of not having time.
That's so true, because as the tool itself, like you said, is so easy to use. It shouldn't stop them from just registering and start using it in their practice. Thank you so much. And I think we have one last question and then we can wrap up. Is that okay? Can I go ahead with that one last question? I know we are like a couple of minutes over, but all right. So in a clinical setting, which biomarkers help track whether a cancer patient is responding well to nutritional support? I guess this is a practice-based question, so we can just, take it offline and send it to them, or we can answer whichever the speakers decide. All right, then I'll take the silence.
This is nutrition, and I don't think it's clinical.
Okay, all right. Thank you, Dr. Radha. So we will get back to you on that question. We'll respond to that question later offline. And I think that's pretty much. And I know we will be getting many more questions, but we will have to cut in the interest of the time of our speakers. Again, I would like to thank each of you for being here, in spite of your busy schedules, in spite of different time zones, being here and talking about this global initiative on cancer research. It's extremely important with how the cancer rate is increasing day by day in every country. So thank you so much, Dr. Vanessa, for wonderfully designing this tool and making it available to us through NutriHealth Foundation. Thank you, Dr. Esther, for contributing to the tool and making it more diversified and easy to use for the dietitians across the world. Thank you, Dr. Radha, for being here, giving your expert advice and adding value to the tool and to the discussion today. I would like to thank each of you from bottom of my heart for being here and contributing to this webinar and in general to this tool. And also to all the audience, I would like to let you know that if you have been on this webinar from the beginning and you would like to get a participation certificate, please fill out the form that we have posted on the chat and send it back to us. And then we will get back to you with the participation certificate. If you would like to check out the tool, please do write in that form as well, and we will get back to you. You can also look at the NutriHealth Foundation website for more updates and more tools. Not just the cancer research, NutriHealth Foundation is going to be collaborating with many more experts across the globe, and we'll be coming up with many more topics that are going to be value addition to the dietitians who are practicing nutrition across the world. Thank you again for this wonderful opportunity. I would like to thank each of you for being here on NutriHealth Foundation's platform and sharing your thoughts and opinions with us. Thanks, everybody, and have a great day.
Thank you. Bye-bye, Vanessa. See you again.
Thank you.
Thank you, Esther.
Bye,
Thank you.
everyone.
Thank you, Dipti.
Thank you, Kiran, for having us.
So,
Thank you.
thank you. Thank you, everybody. I think it was a very good session. We got really to the point what we wanted. So I look forward to the data collection actually getting started. Thank you all.
Yes, that's next.
Yes. Okay. Thank you very much. Bye-bye.
Yep.
Good night. Good day to you, Vanessa. Good day.
Thank you.
Dipti.
Bye.